Good afternoon, everyone. My name is Indranil Chakravorty. I'm an acute physician and also a chest physician. I work in acute medical unit at St. George's, and I may have met some of you already, and I'm also the director of medical education at St. George's. So it's a delight to be able to talk to you on an update on medicine particularly, but also about a safe return to practice. And I'm going to take a few minutes to bring you up to date with what I think you should know. And then if I can join later on, although I have a clinic at the moment, I will be happy to take any questions or comments. So thank you for your patience. I'll move to my slide presentation. Hopefully you should be able to see this. So returning to training after a gap for whatever reason is usually quite a anxiety-provoking issue. And we know that the skills that we normally learn and practice on a day-to-day basis are easily can become rusty. So there's no harm in admitting that or recognizing that that you need a little bit of time to bring yourself up to speed, and that's a perfectly normal thing to do. And as an organization, we ought to be doing much better in supporting, and I'm really grateful to Rosie and for Health Education England in recognizing this and supporting you in this. So let's look at what is it that you need to know. We're going to touch firstly, because of the big P, the pandemic, on personal protection. And that's probably paramount. We have to look after you first before you can look after our patients. We're going to touch on COVID-19 guidelines, which keeps changing. And I'm sure by the end of this talk, we would have a new guidelines. We might even touch on Monkey Pox, although I'm not sure I know enough about it. We'll talk about treatment escalation plans and why that has become really, really important in how we deal with our patients. We're going to talk about how do you make the best use of the limited space we have using remote monitoring, telephone clinics, video consultations. We'll also touch on how we can maximize our learning opportunities, both on face-to-face contact or on ward duties, and also when you don't have to be physically present using a digitally enhanced hybrid model. And finally, I want to touch on mindfulness and well-being, which is absolutely critical for us. So talking about personal protection, let me start off with saying that vaccination is key. And I'm sure that when you return, if you haven't done it already, you should sit down with your educational supervisor and go through a risk assessment tool. It's a very straightforward risk assessment tool, which basically identifies any particular vulnerabilities that you may have and allows us as an organization to recognize them and to take appropriate advice from occupational health or from your specialist or your GP, and basically try to make the adjustments necessary so that you can carry on working and carry on training, but not put yourself at any additional risk. The first step is making sure that you're fully vaccinated. At present, it would involve having a third vaccine or the booster, which most people have had towards the end of 2021 and early 2022. So if you haven't had it yet, and you are more than 3 months from your last vaccine or last COVID episode, please do make contact with occupational health or your GP and make sure that you've got the vaccine. We're not sure as to how the vaccination might change going forward, but the current best estimate is that we will have at least an annual, if not biannual, vaccination for both influenza and COVID. Now, the other important thing is about personal protection is about PPE. or equipment. So we are still using gloves for all our patient contact. We're using aprons, especially to protect your personal clothes, and also making sure that, although not mandatory, that you have clothes that you can easily wash properly. So scrubs are pretty welcome. Some wards have scrubs in abundance, like ITU or emergency department. Medicine is a little bit hit and miss. Surgeons obviously use scrubs when they are in theater. So I would encourage you to consider investing in some scrubs or looking to source them. Make sure that you take them home with you and wash them on a regular basis so that at least your personal clothes are protected from this. In terms of aerosol generation, in particular areas like ITU or high dependency unit, or in the ADU in AMU or in emergency, you may have to participate in activities which require intubation, require high flow oxygen, require CPAP or BiPAP, and make sure that if you are in spaces like that, you are using appropriate protection from aerosol, and that includes an FP3 mask. If you're going to have more than just a few minutes contact, and do read up about the current guidance, which is due to come out probably in the next week from Department of Health and from the Trust on how to deal with monkeypox and whether further vaccination might be required. As I mentioned, the schedule is, first, second, and booster at present. If you have any symptoms, we understand that symptoms are pretty mild post-vaccination, and just taking some symptomatic relief fluids, antipyretics or analgesics are probably adequate. Especially if you're pregnant, it is very important that vaccination is up to date, and obviously get this guidance as you would. New variants are always coming out. At present, they're not making sufficient changes to our practice. And overall, because of the mass vaccination that the population has had, we are seeing much less in terms of COVID severity. But we are more worried now of the post-COVID complications, and especially for this huge deluge of long COVID, which is coming our way. Along with that, we are interested in looking at recovery, and especially recovery of surgical procedures and oncological procedures or post-oncology chemotherapy, which are also significant areas for us to consider. I'm not qualified to talk about children, but definitely seek guidance if children are involved, or if you are looking after children, on the appropriateness of infection control measures as well as vaccination. In addition to what I've just mentioned, there are simple basic stuff like don't touch the mask, change the mask at every opportunity, especially after 4 or 5 hours, or if you're taking it off to have food and drink. Make sure that you try to avoid direct contamination. And when you're dealing with a patient who is suspected to have an infectious condition, the generic guidance is you try to have minimum contact time. Try and make most of your decisions along with the data you have at a distance or in a protected place. And when you go in, when you have to do your examination or talk to the patients, try to do it in a way that is quick, efficient, and doesn't expose you to unnecessary aerosol. What happens if you have any symptoms? This is quite an important aspect to consider. So if you have fever, loss of smell, which is a very common symptom, or upper respiratory tract, symptoms of cough, phlegm, or breathlessness, do consider COVID as a possibility, although you've probably got 50% chance of getting a non-COVID respiratory virus. Inform your consultant or your rota coordinator at the earliest opportunity. Some people still have lateral flow test kits available, so if you have one, use it. If not, try to get hold of one. PCR tests, I'm not sure are as easily available through the government at present, but certainly we are still doing it at the trust. So if you do need one, be in touch with your line manager and they will arrange a rapid test for you. If you are free of symptoms, if it's not COVID and it's not any other infectious condition which is going to put you or others at risk, then definitely come and help us attend your duties. Sickness rates are at about 30% in the trust, which makes a huge pressure on our patients and on the rest of the services. So if it's safe to do so, we would like to see you. Self-isolation rules will change. At present, if you have a negative lateral flow test on day 5 and day 6, or 2 consecutive days, then you should, and your symptoms have resolved, then you are free to return. When should we consider COVID? Still, again, have a high index of suspicion. Anybody with any respiratory symptoms, any fever, any confusion, headache, especially GI symptoms, people with abnormal liver function tests, diarrhea, abdominal pain, or vomiting, and chest pain, especially atypical chest pain where troponin and D-dimers may not be hugely elevated, could also be a presentation of pericarditis and myocarditis. So do think of COVID, consider the initial isolation, ask for a rapid PCR test, then decide on appropriate placement for the patient and appropriate treatment. We still have the availability of procalcitonin, so you can decide between a viral versus bacterial infection. And the lymphocyte count is still a valid way of picking up whether a lymphopenic patient could be having COVID or a viral, acute viral illness. CRPs of usually above 75 indicate that either there's a cytokine storm or that it's a bacterial infection. D-dimers above 1,000, I would certainly consider thromboembolic episodes. Troponin can be elevated in patients, usually not above 50 to 75. And a respiratory viral PCR, if they're COVID negative, is certainly worth considering. So if you do suspect or confirm a diagnosis of COVID, look at the guidelines, use full precautions, especially FP3 if you are doing any aerosol generating procedure or the patient is vigorously coughing inside a closed space. Request a PCR to be done, which results are usually available within 4 hours. Repeat it if the clinical suspicion is high. We have an excellent infectious disease team available, and virologists who you can call and get appropriate advice, especially if you're in any doubt. Consider the contact tracing, and especially consider there may be other vulnerable household contacts of the patient index patient that you're dealing with. And certainly remember to ask for vaccination status. And if they have been vaccinated, make sure that you've got an idea of timing, because we know that antibodies from effective vaccination usually wanes between 3 to 6 months. So, definitely consider that, and also consider patients with immunosuppression or on drugs like methotrexate, on recent chemotherapy or anti-transplant drugs. Now, the other big thing to consider, especially in the last 2 years, that we've seen the association of thromboembolism with systemic inflammation that patients with COVID have had. And this could be present in patients who've not needed to be in ITU, not needed oxygen, and only present with an atypical chest pain or tachycardia or breathlessness. So again, high index of suspicion. Anybody with chest pain, consider pulmonary embolism as a possibility. Definitely look at a D-dimer. Fortunately, in our ED, D-dimer is probably done for everyone who's got a cough and a sneeze, which is not a bad thing. You look for any Ecg changes, obviously look for things like atrial fibrillation, flutter, which is quite common, and any ST or T wave changes. Especially oxygen saturation may be 92 to 93%, which in otherwise fit individuals is low. So definitely consider the possibility of hypoxia. If it is safe to do so, you could even walk the patient or around their bed to see if increasing exercise increases the VQ mismatch. Look at x-rays. Many patients we now find have no x-ray changes, and definitely if the index of suspicion is there and the D-dimer is indicative, consider a CTPA. When D-dimer is negative or very low, the possibility of PE or thromboembolic is still quite low. So I wouldn't go down the CTPA route in patients like that. Look at the treatment guidelines. We're still doing oxygen as the primary, dexamethasone in mostly everybody with hypoxia. Considering antivirals if it's safe to do so within, and there are no contraindications within the first 5 days of start of symptoms. We are needing less and less of the anti-TNF alpha agents. There are new studies in place. So again, look at what is currently available, talk to the infectious disease team, and usually continue the normal medication that the patients are on, and always consider enhanced thromboprophylaxis according to the current guidance. And at every possibility, consider enrolling people in trials. And there's at least 3 or 4 trials which are on at St. George's at present. So definitely consider that. The other big thing that we have learned in the last 2 years has been the validity and the importance of treatment escalation plans. So as a trust, the policy is that we want a treatment escalation plan in every patient at the first opportunity to do so. We also want to make sure that a CPR decision is carefully considered, discussed, and documented, especially through the form on iClip. We want to make sure that that discussion is held with someone at an SPR or consultant level, if it's possible to do so, because that allows you to have a discussion and consider all the options. If your consultant is not available, there's always a possibility of an ED consultant who are very happy to have conversations like this with you, or the critical care outreach or ITU team who may be able to provide a slightly a different perspective, which makes it easier to make these decisions as a consensus. If there's any doubt, obviously, and you cannot resolve it, escalate it definitely to your consultant and make sure that there is a senior level decision on this. Always, it's important to involve the patient if possible and the next of kin, even if it's one of the most difficult things for us to do, because a majority of problems that we face are due to patients or relatives who either have not been informed or didn't have a chance to discuss it, and therefore feel that their relatives have been hard done by. And it's something easily avoidable once we have an opportunity to do so. Now, there are situations where you're either too busy, it's too late, and then it's not possible to have that decision. When in doubt, I would say leave people for escalation if you're not able to clarify that in time, because it's safer to consider that rather than discover later that it should whatever decision you took wasn't the right one. And obviously iClip documentation is the only proper way of having that, and we are still seeing 1 or 2 cases where iClip documentation in the ward round notes versus the actual TEP form are different, and that can lead to a lot of confusion and heartache later on, and obviously inform the nurse in charge. The trust has access to the Charlson Comorbidity Index, which is on the intranet and in the Grey Book, so definitely consider that, and that will give you an idea of how our guidance on treatment escalation plans fits in with the comorbidity index, and that is something very useful. You don't have to use it absolutely word for word, but definitely as a guide. Let's talk about a few case studies of patients that you may come across, probably with less frequency now that we are seeing a dip in serious patients with COVID. So the first patient is an 86-year-old who presents with a positive diagnosis of COVID. She's hypertensive, on an ACE inhibitor, advanced chronic kidney disease, has diabetes, has a previous CVA, although did not have much residual disability, and exercise tolerance is around 100 yards just because of frailty, and lives in a sheltered accommodation. On presentation, classical chest X-ray with bilateral widespread infiltrate, blood pressure on the lower side, and tachycardic, EGFR probably at the baseline, and with slight degree of confusion, although the GCS was adequate. So someone like that, you would consider a treatment escalation plan, discuss a CPR decision making, find out whether the suitability of taking them to intensive care should their condition get worse. Looking at multisystem disorder, you're more likely to make a decision that intubation and ventilation for this patient may not be adequate, and you may stick to something like OptiFlow. But definitely, it's something to be considered on a case-by-case basis. Make sure that the treatment escalation plans are adequate, and also that patient is on the right treatment, which would include dexamethasone and an antiviral agent and thromboprophylaxis. Let's look at case 2 quickly. Middle-aged, I guess, man with presenting with chest pain, previously unvaccinated, smoker, generally not very compliant with lifestyle or medication. Initial D-dimer was moderately elevated, CRP was high, and a BNP indicated that there would be some right heart strain. EGFR was low, and there's a history of previous heart disease with an ejection fraction which is moderately reduced, and a lot of alcohol and homelessness and poor nutrition in the background. Again, consider the possibility of pulmonary embolism, consider the possibility of COVID affecting the heart, and then try to have a discussion on escalation plans. Looking at the overall picture, although the patient has many comorbidities, it would seem that escalation appropriately to high dependency or ITU, if necessary, would be appropriate in this patient. So again, consider that, document your decisions, and look at this carefully with colleagues. Let's look at case 3, female of African American heritage, middle-aged with active COVID. And interestingly, this is a patient who came from a family of anti-vaxxers. So they actively believed that the virus did not exist, that it was all a government conspiracy theory, and were not interested in doing any vaccination. The reason for admission was obviously hypoxia and cough and unable to manage, but they were not willing to consider COVID as a particular diagnosis. Interestingly, they had lost their elderly parents just a year before to COVID, but were still not convinced because of that. In addition to fever and cough, the patient also had significant diarrhea. So good reason for us to make sure that they were nursed and managed in isolation. And mental health is a very, very common comorbidity in patients with COVID, and especially with pre-morbid mental health disease like this patient had with schizophrenia. It can complicate matters significantly because they're not willing to engage. They're sometimes the index of suspicion for them towards us is usually very high, and it made it much, much harder to manage a patient like that. So because of the severe, profound hypoxia, the patient needed to be on OptiFlow. They would have qualified to go for ITU, but they were not willing to consider that at all. And we were every day struggling to decide whether the patient had capacity to make these decisions, and in mental health conditions. So we did seek help from our psychiatry liaison colleagues, who were really helpful to come and do some dual assessment and decide whether the patient had capacity. So eventually we decided the patient had capacity to make the decisions on this, and we had to comply with their, as they got better, with their decision not to accept treatment. So we couldn't give dexamethasone, we couldn't give antivirals, and if they had reached that point of needing intensive care, we would be in quite difficulty. But fortunately, patient, although the X-ray shows bilateral infiltrates continued to improve. And as soon as they were off the OptiFlow and not needing a lot of oxygen, they decided they were going to get up and go, and we were unable to stop them. So we had to let them go, and we did inform the GP and the rest of the family about the fact that they were considered a public health risk. But again, definitely don't do this alone. Do this with your consultant. And in this case, I remember having at least one other physician colleague and a mental health colleague, and we three of us made the decisions about capacity and treatment together, just to make sure that we were adequately giving the best possible advice and also protecting ourselves. Eventually, the CTPA also showed PE, and the patient was offered treatment with oral anticoagulant, and still refused to accept the treatment. And we did give the treatment, and I'm not sure whether the patient actually took the treatment or not, but we certainly decided that we were not in a position to enforce any treatment on them without compromising their basic human right. Hugely challenging. Do not wish any of you to have to face something like that, but there is a way of managing this. The fourth patient I want to bring to attention is somebody with a chronic brain injury who's dependent for ADLs, is managed in a neurodisability hospital, is PEG-fed, has a tracheostomy, and has had multiple admissions with resistant bugs, and then eventually picked up COVID, perhaps from visitors, and came to hospital. Required a lot of oxygen on OptiFlow at 80% oxygen. SATs were barely touching 90. Needed huge amounts of suctioning with physiotherapy. Very high CRP, which is very much indicative of severe sepsis, possibly definitely bacterial. High temperatures. We had to make a very complicated decision on treatment escalation and CPR. The family were not willing to accept it. ITU were not willing to take the patient if they were to go downhill. And even when we considered the condition without COVID, we found that the overall deterioration prior to COVID that the patient had reached was not compatible with a full recovery, and therefore we had to, again, with consensus, especially with very good input from ITU colleagues, had to make a decision that this was on a medical ground and not appropriate for ventilation. The family were not happy. They approached PALS, and lots of discussions and deliberations continued. This is not that particular patient, but a similar patient that we had around the same time. Again, was considered not for resuscitation, but eventually when we did look at the X-rays and found that there was a total whiteout on one side of the lung. Now, it's very difficult in situations like that, whether it is down to a simple sputum plug, which has closed this off, or whether there was any additional possibly neoplastic lesions. But in situations like this, where it looks like a very quick deterioration and an obvious cause which can be dealt with, I would consider a short stay in ITU, a bronchoscopy, perhaps visualization and discussion. Anyway, I just put it there to say that situations like this are quite complex. If you do have to face them, always consider taking appropriate advice and guidance and managing this. So that's a flavor of some of the patients that we are getting now, in addition to the usual medical patients, which are always commonly seen. I'm going to touch on one of the other things that is quite important, which is preparing for your shift, making sure that on a 13-14-hour shift that most of you will be ending up having, that you have appropriate sleep and rest beforehand, that you bring with you some refreshments, Many wards have access to water, access to food, which is quite good, not so much at night time. So definitely come prepared. Make sure that you are hydrating yourself, and it's very easy to go about 6-7 hours without having a drop of water. Many ward areas now have access to water, so definitely bring a bottle. I find that to be the best, although I'm not the best person to take that advice. But I have found the water app, which you can download from Google Play or Apple Play, is very good because it reminds you every hour that you need to drink water. And even if you follow like 20% of the advice given by the water app, you would probably be better off not wrecking your kidneys. The other important thing is to take breaks. Now, I know it's very difficult, and you'll never be in a position where the workload is such that you will be able to take breaks without really feeling guilty about it. But remember that if you are not looking after yourself, you cannot do good service to your patients, and that is absolutely paramount. So definitely put your tools down, 20 minutes, 30 minutes, go and sit down somewhere away from the workplace and just refresh, rehydrate, and come back. The other important thing that I cannot stress enough is having a decent handover. So remember, you do not carry things with you. You need to hand over in an appropriate way at the right time and leave on time. Don't stay over just to do one extra thing or just to do another extra thing. Definitely make a very good threshold of deciding whether this needs to be done today or then hand over. If it can wait, then keep it for later. Make sure that you have scrubs. I would definitely recommend it. They're not really expensive. Get your ID sorted out. Make sure the smart card is working. Make sure that login is there. Make sure you get some iClip training. Just takes an hour with one of a super user so that you are fully aware of all the functionality, especially the new discharge method that we have on iClip, which and also if you're doing clinics using Dictate IT, make sure you've got an appropriate login for that. Make sure your induction is adequate. Don't miss your induction. And if you end up missing it, ask for a bespoke induction for you. And if, as and when you arrive, people will be busy, people will not recognize that you've been away. So definitely tell people, look, I've been away. I've had, I've just come back. So I may be rusty. There's no shame, no embarrassment in saying that. One of the things that I find very useful, irrespective of whether you're coming back into training or you've been in training, is to do anticipatory thinking, or what is called forward thinking. So before you approach your patient or any patient, obviously look at the notes, make a list of potential differential diagnosis, relatively easy. Make sure that you remind yourself, what are the things in the history that I don't want to miss? And make sure that you remember, or just in your mind, go through what steps in the examination that you must do. Make sure that you do it in a proper, exposed, way with whatever is the appropriate thing, and don't bypass anything. Make sure that the conditions are right for you to do a proper examination. And even if someone says that this is happening or that is happening, don't take things on face value, because sometimes busy clinicians miss things. So make sure you go through everything, verify, because your patient deserves that. And then obviously look at all the investigation reports yourself, or the pictures or the actual figures. Don't just accept the values, because we are human, we make mistakes. So make sure that you have checked and verified everything that you look at, and then your chances of making a mistake yourself are much less. And definitely when you're discussing with colleagues, your registrars, consultants, colleagues, make sure that you've written a short summary, or put a summary of 3-4 lines. Make sure you present the positive findings in the way that you would want to. Encourage your seniors to examine the patient so that they can verify your findings, and also that increases your own confidence and consolidates your knowledge. So definitely I would ask them to cross-check my findings, and then when in doubt, or even when you're not in doubt, just look at UpToDate. We have access to UpToDate from the intranet at all times. Excellent resource, takes 5 minutes. Look up what is the current evidence base for what you're dealing with, and that will be hugely important. And then the final thing is, don't miss any training. Now, in spite of all of this, you will have really either very interesting or exciting times, or sometimes very difficult times or very challenging times. So take time when you're at home or later on to either sit down and reflect by yourself or with a colleague or with a family member, just so that you can go through what happened. What have you learned from this? What would you do differently? And how do you feel? Always acknowledge and recognize the feeling that you're getting. Be mindful of the fact that you are human and you need to your own safety, your psychological safety, your physical safety, and you have to look after yourself because no one else will. Just a quick reminder of trust values. Even when we are challenged, we have to, we want to be kind to each other. People may be going through different challenges which may not be visible. Let's be respectful. Let's do our very, very best, and let's be responsible for the actions that we're doing. I don't know if you're aware, but if you're not, this is a good time to look at the good medical practice guidance from the GMC. This is being updated after 10 years, so you may have a chance to contribute to make the GMP better, more relevant for the current time. Definitely look at the TEP guidance, and remember that we have a legal duty to make those decisions and also inform the next of kin on that decision. In spite of all that, there may be absences from colleagues because of sickness. There may be a huge, overwhelming number of extra patients that you have to see. And if you do have to stay over for patient safety, definitely make sure that you're reporting this to the Guardian of Safe Working Hours, and that is documented. If you're worried about any aspect of your training, of your work environment, definitely talk to your reps. They have a mechanism of escalating, voice your concerns or suggestions of making things better in your local faculty groups. Talk to your ES. They are there to help you. They're there for mentorship and pastoral care. Be honest, open up, talk to them. They have lots of experience, and majority of them will do a good job of guiding you. The Junior Doctors Forum is there. It's an excellent resource for making sure that things that you think will make it a better organization, a better place, can be taken through. The Chief Registrar chairs that and is responsible. Contact the Chief Registrar, tell them about what you think. And if you're really worried about something and you're not feeling safe to raise it within the organization or your teams, there is the Freedom to Speak Up Guardian, who is independent of the trust and will maintain full confidentiality. So definitely look at that. I'll leave you with the last slide, which is about medical careers. So this is about, continue your flexible training if you can, find some time, do other things. Majority of us will be better off in what we call portfolio careers. So not just doing clinical medicine, but actually also doing other things at the same time. And that could be a leadership role, could be research, could be teaching fellow, could be voluntary work in other places. And definitely, you don't have to be on a mill and go, stage by stage of training for the next, 7-10 years of training. Take time out, go and do other things. You'll only enrich yourself in doing that. Global health is a fantastic place to be. Infectious diseases, has had a huge interest. Some people do expedition medicine. Depending on, what your interests are, sports medicine, go and do something else. Go and get, a qualification if you want, or even if not, pursue other things which can enrich your own career, make it more diverse so that you can really enjoy your time. And some people even go on and do an MBA, management. A degree will teach you incredible skills, and there's a lot of support available and a lot of bursaries that you can have access to do that. So those would be my tips, but welcome back to training, welcome back to St. George's, and welcome back to your clinical careers. And if you do need any help from us, Rosie obviously is there for support, or the postgraduate medical education team is available, and feel free to email me or contact me if you need to have a chat about something that we can help you with. So certainly welcome. Thank you.